Hello, everyone. Welcome to the Ophthalmology Business Podcast. We help you develop your ideal practice with help of other doctors and experts. The topics we cover include marketing, management, leadership, recruitment, HR, mindsets, and more. I am Dr. Deep Parikh, one of the co-hosts of this podcast. Every listener of this podcast is welcome to join the Ophthalmology Business Academy, www.obacademy.org. The membership is on us, and it's our gift to you.
Are you ready to revolutionize healthcare with AI and technology? Join our free webinar with Dr. Anish Kapoor on November 1st, 12 p.m. ET, to learn how to use AI and tech for practice growth. Visit www.obacademy.org to register. See you there.
Today, I'm excited to talk to Dr. Cynthia Matossian, founder and past medical director of Matossian Eye Associates. She's also the CEO of GP Ophtho, a group purchasing organization for ophthalmology, and chief medical officer of two pharmaceutical companies, Glint Pharmaceuticals and Viziox. She is also founder of the American College of Eye Technicians. Pleased to welcome her here today, and we're going to talk about optimizing dry eye care in your practice, clinical excellence, and business success. Let's jump in.
Deep, thank you so much for inviting me and for that wonderful introduction. If you could see me, I am blushing. So thank you. I feel so humbled by your kind words.
Dr. Matossian, before we get started, why don't you take a minute to just tell us a little bit about yourself? Who are you and how did you get into ophthalmology? Please share your story.
It's a long and circuitous story, as I'm sure many of our stories are. Very few are direct and straight like an arrow from point A to point B. I went to medical school to become an ophthalmologist, actually. I didn't just stumble on ophthalmology because I wanted a field that was a happy field. That was very important to me. I'm a happy, like positive energy kind of person. I see the glass usually very full, if not overflowing, instead of half empty. And I wanted a field where it was a combination of surgery as well as in-office patient care. To me, that balance was critically important. And there aren't that many fields in medicine where you can do that almost 50-50. Ophthalmology is one of those. Plus, I wanted to see men and women. And at the time, I wasn't sure if I wanted to exclusively focus on adult ophthalmology patients or also interweave pediatric patients in there. I wanted to have these options, and consequently, I chose ophthalmology, knowing that it was tough to get in. It's one of the most competitive fields, and we even have our own very special application process, which not too many other subspecialties within medicine have.
And it's really remarkable. I mean, I think you hit on a lot of things that a lot of medical students going into ophthalmology love about ophthalmology. That sort of drives them into it and interests them. And I think that's part of the reason it remains, to this day, such a very competitive specialty.
I agree completely with you. And I think so many people say, I wish I had discovered it. I may have gone into it because of the limited exposure that fourth-year students get in electives. They can only usually have a choice of 2 or 3 or 4, maybe. They're just not too many people are getting the intro to ophthalmology, and then they find out about it later and regret they didn't know about it.
That's absolutely right. Tell us a little bit about dry eye and what role does dry eye play in an ophthalmology practice?
Steve, I'm so glad you asked that question. I think the answer would have been very different if you had asked me this 10 or 15 years ago. But now the answer is very different. There is a hyper awareness of the importance of the tear film and the critical role it plays in different subspecialties within ophthalmology, in refractive corneal surgery, in refractive lens-based surgery, in cataract surgery, even for monofocal IOLs. If that tear film is not properly optimized, and if we are capturing data through our keratometers, topographers, tomographers, etc., that is unreliable because the tear film is dysregulated and completely erratic, we're going to end up with numbers that don't make sense. And even if we plug them into the best, most recent IOL formulas, the outcome may be a refractive surprise for both the surgeon and the patient. And we know what happens when a situation like that occurs. Obviously, the patient is very unhappy, they want their money back, or they start giving the doctor a 1-star review and writing very negative comments on the website, which are impossible to take down. And it just takes up so much chair time to undo what was done. Can it be fixed? Yes, but it's a long process.
Right. Unhappy patient leads to an unhappy ophthalmologist. So I think addressing this early on beforehand, making sure you have correct measurements is all crucial.
Very right about that. Actually taking the time up front to diagnose the ocular surface. Is there dry eye? I used to approach my patients that everybody has dry eye, all my cataract consults actually, that they had dry eye unless proven otherwise. I actually had to rule out dry eye in order for me to proceed. And basically, so many people in that age group have a component of meibomian gland dysfunction, lead margin disease, ocular surface disease, tear film dysregularities. So pretty much most had it. Then comes the education part. Deep, unless we tell our patients that they have two distinct diseases going on. One is their ocular surface dry eye. The other is their cataract. The cataract we can cure. One surgery per eye, you're done. You're not going to grow another lens that's opaque. Whereas dry eye is going to require a lifetime, literally a lifetime, a forever type of treatment. And if they don't do it, then the money that they may have paid for an advanced technology IOL may actually not work as well as they had hoped because they have intermittent blurred vision. They have fluctuations in their vision, and they're going to, of course, blame it either on the surgeon or the implant.
You're absolutely right. And to add a little bit of a different perspective, Cynthia, one of the things that I've noticed dealing with a lot of retina patients in my practice is a lot of my macular degeneration patients, which again are in that same age group as probably the cataract patients, maybe a little bit older. A lot of times they come in with blurry vision. They think their macular degeneration is getting worse. And I tell them, we do an OCT, we do advanced imaging. We say, hey, actually the macular degeneration's okay. Your vision's decreasing between your visits due to dry eye. And it's so prevalent. And I really like your idea and concept about ruling out dry eye and assuming the patient has dry eye because it is that prevalent.
You're right. And also, Deep, as you know, because you're a retina specialist, all the retina patients who get recurrent injections for their maculopathies are actually suffering from a component of dry eye that is exacerbated by the betadine or whatever prep is being used,
Absolutely.
the anesthetic that's being, placed on the eye prior to the injection, the drops. Some doctors use post-injection drops, some don't. Some put betadine in, some don't. There are different techniques, as you know, and all of these are causing a variant of iatrogenic tear film issues.
Absolutely. 100% agree. And I find that the majority of these patients, are undertreated in terms of their dry eyes.
Yes, I know one retina specialist who recognized this quite some years ago. I want to say maybe 5-6 years ago. And he does LipiFlow treatments on his patients in whom he's giving injections. And they are, as a cohort, doing pretty well because their ocular surface is healthier. They're getting their heat and evacuation treatment, and he addresses their dry eye, or I believe he might have an optometrist who works hand in hand with him, who does the dry eye treatments for his patients who get repeated injections.
I think that's fantastic, and that makes a lot of sense.
It's a great business model, actually. Patients are happier, their vision is better. And for these patients who have already decreased vision due to their AMD, fluctuations make a big difference. So you want to have as clean, as good, as healthy a lipid layer and a tear film in these patients to give them their optimal potential visual acuity.
Absolutely. Absolutely. In terms of your preoperative patients, could you please describe what a preoperative dry eye evaluation looks like?
As cataract surgeons, or really any type of eye surgeon, we have to first educate the patient so they have a clear understanding and appropriate expectations of what to look out for and what to expect after their procedure. Secondly, treating and really getting the ocular surface as optimized, as healthy as possible, requires an aggressive treatment modality. This is where we really try to use so many things in our toolbox, including a short, maybe 2 to 3 week course of steroids, maybe 2 to 4 times a day, placing them on oral omega-3s, perhaps doing a heat and evacuation procedure in the office, perhaps doing an eyelid margin treatment, anything to really stabilize that tear film. Then there's a secondary treatment, which is not as aggressive, it's milder, and that's the maintenance therapy. That's where immunomodulators come in. You can start them pre-op, but most of them take at least, 2 to 4 weeks, if not a few months, for their benefits to start to be perceived by the patient. So this way, if you start them pre-surgically, by the time they are off of their NSAIDs, their steroids, and their antibiotic, hopefully their immunomodulator is kicking in, and they are going to then reap the benefit of their more advanced technology IOL or their monofocal IOL, whichever they chose.
In terms of their maintenance therapy, are you continuing this sort of indefinitely, being as this is a chronic condition, or do you sometimes pull back on that?
Well, the aggressive is prior to surgery. Post-surgery, it is maintenance because it is a lifelong disease, Deep. We know that. And we know that once a meibomian gland is damaged, drops out, we cannot do a transplant of a meibomian gland, maybe in the future, but not right now. So these folks will need oral omega supplements for life. It's an essential fatty acid. The body doesn't make it. They have to consume it. They might need a moisture heated mask to keep the viscosity of the meibum at the right consistency for it to flow like olive oil instead of being really pasty like mayonnaise or Cheese Whiz or toothpaste. Then they might need an anti-inflammatory product, not a steroid, because clearly we can't leave our patients on steroids indefinitely. Clearly, we can't leave our patients on steroids because of the consequences of glaucoma and corneal surface issues, but they might need an immunomodulator indefinitely. Or they might need maybe an annual or a semi-annual in-office interventional procedure to keep the glands nice and healthy. That's the deep clean just like the dental model where we brush and we floss daily. However, twice a year, we go to the dental hygienist for that very thorough cleaning.
Is there a dose or a brand of omega-3s that you find most effective?
Yes, not all omega-3s are the same. There are a few brands that stand out, and they are, I would say, considered among the best ones on the market. PRN, which stands for Physician Recommended Nutraceuticals, is a great omega-3. They have spent a lot of money and invested a lot of time in clinical trials. I was one of the authors of a paper. I was involved in the clinical trial as a principal investigator, and the data is really solid. We published it in Cornea some years ago. Carlson, which is over the counter, you can order it. That's a good brand. Nordic Natural is also over the counter. That's a very good one as well. And Science-Based Health has a different pathway with omegas. They're not omega-3s. It's a GLA pathway, and it also really helps the tear film. So all of these are good brands. Whereas some of the cheaper brands that you buy at the corner drugstores, they are in a different formula called the EE. The EE stands for ethyl ester. And the ethyl ester formulas don't absorb through the GI tract. Instead, they cause this fish burp and really embarrassing fish taste in the mouth. And people just say, this is ridiculous. And what do? They stop taking it and
No one
toss
wants
it in the
that.
garbage.
Yeah, exactly. No one wants that. No one wants
Exactly.
that. So that's excellent. So thank you for sharing a little bit about your approach to treatment. What about the preoperative, just the evaluation of a dry eye patient? What are you looking for? What special tests are you obtaining in the office? And are you doing this all in one day, or do they come in, different appointments? Sometimes when their tear film is better, sometimes when it's worse. Tell us a little bit about your approach.
And this is where I think many practices sometimes get in trouble because they see the patient for a cataract consult, and on that day, they do the pre-surgical measurements and calculate the IOL. Well, if the tear film isn't in an optimal form, they're going to get into trouble, as we discussed earlier in this podcast. What I do is all my cataract consults, I assume they have dry eye, and we do the following tests on every single cataract consult. The first thing we do, our technicians ask 3 questions. We don't do an OSDI survey or a speed survey. It was just taking too long. And sometimes the process of calculating all the numerals results to tabulate the summary. There were mistakes being made by technicians and so forth. So we decided not to do that. The 3 questions we ask are, number 1, does your vision change throughout the day? We don't use the word fluctuate because a lot of patients honestly don't know what that word means, right, and are embarrassed to say that. So they just say no as a defensive mechanism. But when we change it to, does your vision change throughout the day? We were getting a very big response that yes, it does. It changes throughout the day. Question 1. Question 2 is, how many times a day do you use artificial tears? Not do you use artificial tears? How many times a day? Clearly, deep, if somebody said, oh, I use my tears once or twice a month, that's a very different story than somebody who says, I use it 3, 4, 5, 6 times a day. I can't go more than a few hours without placing a drop in. Right there, that history is crucially important. Mm-hmm. And the third and final question we ask by the technician is, do your eyes feel tired towards the end of the day? And if the answer is yes to any of them, then we know there's a component of dry eye. So that's the first thing. The second thing is we do tear osmolarity testing as well as MMP9 testing on every one of my patients because that's giving me objective data. We are scientists. So, yes, we need the subjective responses to those first three questions, but we also need objective measurements, which I share with my patients. And patients love it, just like their cholesterol number or their blood pressure or their weight, whatever it is, then they keep track of that. And the final thing that we do is mybography using a LipoScan, a machine where we actually take images of the meibomian glands and demonstrate the level of dropout or architectural deformities of the meibomian glands to the patients. And lastly, at the slit lamp, I always use two stains, lissamine green to look at the conch and fluorescein to look at the cornea.
That's fantastic. And are you finding that these tests you're getting reimbursed for, or how do you find that in terms of your Medicare patients and your insurance patients?
I'm so glad you asked that. The three questions don't take so much time. That's part of the intake history. The MMP9 and the tear osmolarity, there are codes which both Medicare and commercial payers pay. It's not a lot of money. You don't get rich from doing these two tests. What you do is you pretty much break even. And in that sense, it's covering your costs, but you become a winner because many doctors don't do these tests. So all of a sudden you stand out as somebody ahead of your competitors in your area. And the patients start really trusting you more and know that there are objective numbers there that they can track over the course of their disease. And post-surgery, we continue to do these tests and to assess not only their improvement, but whether the therapies that I have selected for them or customized for them is actually the appropriate one. There is no reimbursement for mybography. However, if there is a lot of gland disease and the meibomian glands are inspissated and clogged, then I always suggest a LipoFlow procedure, which is a cash pay procedure. So in the end, it all kind of gets covered one way or another.
Understand. And that sort of leads into my next question, which is, how does one integrate dry eye into a practice?
I get asked that question a lot. I would say first, you as the doctor or somebody in your practice has to be passionate about dry eye. If you don't like it, it's never going to be a success. So you have to identify somebody who wants to really roll up his or her sleeves and get into dry eye. The patients are there. You don't have to advertise for these patients. They're the patients who are already in your office. Then you need to build a team. It could be one technician, maybe one front desk person, so that you at least have a small nucleus of a team where you can rely on each other to teach the other doctors, teach the other technicians about what you're doing. In-office tutorials or in-office lectures about the services you offer within dry eye, what the symptomology might be that patients are complaining about when they're calling to make appointments. Without this kind of education intra-office, you're not going to be able to grow that subsection or subspecialty. And also let your colleagues know what you're doing, educate them, because a glaucoma doc, a retina doc, an oculoplastics doc may or may not know enough about dry eye. This way, encourage referrals intra-office, and before you know it, you're going to be so busy that you won't know what to do with your schedule. And then you don't have to get every gadget, every diagnostic device, every treatment modality all at once. Approach it step by step. Start maybe with an imaging device for the meibomian glands. Lissamine and fluorescein, we have, that's very easy to do. Tear osmolarity and MMP9, those are, easy to integrate, but I would say start with one. And then once your technicians are good and you're confident in how to interpret it, maybe 6 months later, add the other tests, and you can build from there.
And that was excellent. One of the things that really struck me is really having the technicians involved here. I mean, so much of this is, better educated technicians, better aware technicians are the ones, they're the ones doing the intake. They're the ones asking these questions before you even see the patient. And oftentimes, the doctor will go to another room, but the patient will be there asking the technician all these questions. So I think you really hit the nail on the head by saying, a lecture to your technicians to tell them, listen, we have these services available. We treat these conditions. Better trained, better educated technicians, I think will really help increase your dry eye practice.
Absolutely. I cannot agree with you more. And many companies, their reps are more than happy to come in either before clinic hours or after clinic hours. Of course, you have to pay your technicians overtime if you ask them to stay more than the normal 40 hours or 36 hours, whatever it is per week, because it's deemed as overtime unless they're salaried technicians. And they will work with them. They will show them how to do these different types of tests. They will walk them through the right and the wrong way of doing it. And they can practice on each other, which is what we used to do. And this way, their confidence level in doing the test is visible through their body language to the patients. And the results are so much more accurate. And you can really trust and base a diagnosis on the results that the technicians are getting.
I love that. I love that. So this we've touched on this a little bit already, but in terms of how a practice can become successful with onboarding a new group of services such as dry eye, you alluded to having the reps from the companies help train the technicians. I thought that was brilliant. Are there any other tidbits you can give us about onboarding a new group of services?
I would say don't overwhelm the staff because they'll just get flustered. Do one service at a time. Let's say you have decided you have maybe your lissamine green, your fluorescein, of course you have a slit lamp, and maybe you have tear osmolarity. Now you want to do something else. Well, the next one might be MMP9, or the next diagnostic test might be meibography. Only get one, practice with the technicians without pressure so that they know how to do it well. And then once that's done, maybe you'll decide, okay, now I'm ready for cash pay, interventional in-office procedures. Well, again, there are many options out there. There are ones that are focused on the biofilm of the eyelid margin through either mechanical or manual debridement or a mechanical aggressive kind of rubbing back and forth of the eyelid margin. Or you can do the heat and evacuate options like iLux, tear care, LipiFlow, or do IPL, intense pulsed light, which treats the telangiectatic vessels around the eyelids associated a lot with rosacea, blepharitis, things like that. But again, don't do all of them at once. Do one and really get good at it. Get the patients educated about it. You may want to put it on your website. You may want to go to your OD network and do some lectures about it. You may want to really, perhaps do a patient seminar, virtual or in office. Again, the message has to get out in some way or another. And then once you really perfect that, then bring on another treatment modality.
I love it. I love it. Excellent points. My next question is, some people comment that dry eye patients take too much chair time and that it may not be profitable to provide these services. What are your thoughts about profitability and dry eye services and that extra chair time?
I hear that comment a lot. And I'm typically not a person who vehemently disagrees with comments, but with this comment, I do vehemently disagree. These are patients who are desperate. They are suffering. They have chronic pain in their eye. It's like a chronic pain patient. They're going from doctor to doctor to doctor, looking for somebody who, A, is going to listen and hear, truly hear what they're saying, and B, provide them with some relief. Once you are that doctor and you hear the complaints of dry eye patients, you can start offering them incremental relief. You are going to have such a revered position in the way they think about you. They will refer so many people to you. So right there, you are going to start getting busier by the number of referrals from these happy patients. And the corollary is, if you don't listen to them and you don't pay attention, they're going to walk with their feet and never come back and leave your practice. Right there, that makes a big financial impact on the patient concentration in your practice. The second thing is the positive reviews. If you ask them to give you reviews, they will, because they're so grateful. You're going to get a lot more 5-star reviews. And patients look at that when they are choosing a doctor to go to. The other thing is that all of these procedures that you offer in the office are cash pay. None of it is covered by insurance. Just like an advanced technology implant, it's cash pay. With cataract surgery, it's once and done per eye. Whereas if you look at the life expectancy and lifespan of these patients, many need 1, if not 2 procedures a year. So over the cumulative lifespan of years of these patients, you are going to make much more money than the one-time several $1,000 IOL. And the level of gratefulness, the level of thankfulness of these patients is undescribable. They are the most grateful group of patients. They become so loyal and your goodwill ambassadors.
Dr. Matossian, you are a absolute wealth of information, and I could literally ask you questions and speak to you about this topic and I'm sure many other topics for hours on end. And I just one last question, and then before we wrap it up for our listeners, but one last question: what are you sort of excited about in the dry eye space in the upcoming years? Is there something an avenue that's under research now, or a new product that's coming out that you're especially excited about?
Compared to years ago when we only had artificial tear solutions and artificial tear ointments, we've come a long, long way with the myriad of prescription products that are available for our patients, with a number of over-the-counter remedies that can be prescribed for our patients, with a number of interventional procedures, both in the office and at home, procedures that patients can do to help their eyelids and ocular surface meibomian gland health. So I am ecstatic at how far we've come in about 20 years. The pipeline is extremely robust. So many companies are working on different ways to deliver product to the eye. There's a cream coming that can be applied to the upper lid, and it can help with dry eye. There are procedures that can be done to help with the different layers of the tear film. So there is so much happening. It's exploding with ideas and really good options for our patients who suffer so much. So I'm delighted to be in this field.
Excellent, excellent, excellent. Dr. Matossian, thank you so much for joining us today and talking to us about optimizing dry eye care in your practice, clinical excellence, and business success. We appreciate it very much. I also want to take a moment to thank our listeners. We appreciate each and every one of you. We cannot do what we do without you. If you like our podcast, kindly share it with your friends and on social media. And please don't forget to write us a review on iTunes or Google Play. Your reviews will help other doctors and practice owners find us. Till we meet again, wishing all of you an amazing week ahead. And once again, thank you, Dr. Matossian. It was such a pleasure.
It was a thrill being with you and speaking with you, Deep. Thank you very much for inviting me.
Have a great night.
Thank you. Bye-bye.